Okay, so we're going to look at some of the alterations in metabolism and regulation. I will apologize, I've got a little bit of a head cold right now, so my throat feels a little scratchy and froggy, so if I sound funny, that's probably why. But I'll do my best to get through voicing over this PowerPoint for you guys. Okay, so I started this slide that just kind of gives you an idea of some pages to find, some of the information that I feel is beneficial for you to review. If you've already looked at this PowerPoint or looked over the content, you will see that we're mainly dealing with three different endocrine systems. That is dealing with diabetes or issues affecting the thyroid, and then we also have something that's affecting your adrenal gland. So when we look at the diabetes information, we're going to focus on whether it be diabetic ketoacidosis or hyperglycemic hyperosmolar state, or HHS. Sometimes you'll see in literature this referred to as HHNS, which is a hyperosmolar hyperglycemic non-ketotic state. It doesn't matter whether it says HHS or HHNS. Those two are the same disease process. So don't think that those are two different things as you're doing any kind of research. And then when we look down at your thyroid, we're going to look at things that affect people who either have hyperthyroidism or hypothyroidism, and that's things like thyroid storm and something called myxedema. And then also when we look at your adrenal system, we're mainly going to just talk about something called a pheochromocytoma, which is a catecholamine-producing tumor that arises in the adrenal medulla. Now, the one thing that all of these processes have in common is that they can cause life-threatening events, which puts the patient in jeopardy. Okay, just like in my other lectures, I always like to start with a little bit of review of physiology. And so if you look in chapter 61, I believe it is, it talks about the assessment of your endocrine system. And your book does a really nice job of breaking down into a very small bit of reading about each of the different glands and the hormones and stuff that they regulate. And so this is a great little place for you to kind of do a refresher. In order to truly understand what's going on with these different disease processes, you have to go back to the very beginning and understand the main primary function of these glands and of these hormones and how they do their regulation. So looking at your thyroid, again, going back to basic stuff, it produces three hormones, the T3, the T4, and the calcitonin. Your TSH, or that thyroid stimulating hormone, is produced by your anterior pituitary gland. The one thing I would kind of tell you too, I think a lot of people get confused on TSH, is try to remember, what does TSH do when somebody is hypothyroid, has hypothyroidism? Does it go up or does it go down? I'm not going to answer that. I'm going to make you guys look that up. But have an understanding what TSH does, because that does help in understanding when you're trying to figure out if somebody has maybe some hyperthyroidism or some hypothyroidism going on. So TSH is very important because it stimulates the thyroid to produce these other hormones. So T3 and T4, they affect all your body systems by regulating that overall body metabolism, your energy production, and also controlling your tissues' use of fat, proteins, and carbohydrates. So it really helps in the process of metabolism, regulating, and that's why if you think about some of the manifestations that you see in somebody who has hyperthyroidism, for instance, where these are being oversecreted, the patients tend to burn a lot of calories really fast. You'll see a lot of weight loss, and it's because they're kind of like their metabolism is on steroids at this point. So it kind of makes sense then that why you see the different manifestations with the disease processes in the thyroid. Calcitonin is something that's also produced by your thyroid gland. It inhibits the mobilization of calcium from your bone and helps to reduce blood or serum calcium levels. So again, it's important that you have proper thyroid function in order to regulate your calcium. It also affects phosphorus metabolism as well, and also serum phosphorus levels. It's important that people get a good dietary intake of protein and iodine in order for the thyroid to produce the hormones correctly. Um, Women in particular, we always preach to women that you need to get enough iodine. And so if you notice in the stores, you often will see salt is iodized, and that is for a reason. It's to help to regulate and to help maintain good thyroid health, because we know it's very hard to get that into our diet. So that's one of the things they do is they add the iodine to the salt to help with thyroid regulation. So the first disease process or emergency, shall I say, from the endocrine system or in regulation that we're going to talk about is something called thyroid storm or thyroid crisis. And this basically is a life-threatening event that causes patients to basically have uncontrolled hyperthyroidism. And this results from a sudden surge of a large amount of thyroid hormone that's being released into the bloodstream, which causes an even greater demand for the body metabolism-wise. Already kind of talked about with hyperthyroidism, you have an excess amount of your thyroid hormones being produced, which increases metabolic demand. And so now if I have an even bigger dump of those hormones, it's going to cause even greater issues with being able to keep up with metabolism. And so that kind of sets off a cascade of events that leads to the possibility that this, like I said, is a life-threatening situation and condition. It is considered a medical emergency, and it does have a high mortality rate if left untreated. So it's important for us as healthcare providers to be able to recognize it, kind of understand what's going on so that we can go ahead and get the correct interventions implemented. So some of the participating or precipitating factors include, of course, uncontrolled hyperthyroidism. So if the patient we know has hyperthyroidism should be taking medication for this and has not been taking their medication, that may be one of the things that leads to this being a potential problem. Also, for these patients, if they should have infection, trauma, emotional stress, all those things, infection and trauma cause extra stress to the body. So just kind of think of it as anything that can cause additional stress to the body. Diabetic ketoacidosis is another one of those processes, as well as digitalis toxicity, or for people who are on digoxin that get out of therapeutic ranges. These are all precipitating factors that can bring about thyroid storm in the patient who suffers from hyperthyroidism. This can also happen if the patient has a thyroidectomy or has their thyroid gland removed. And this happens as just a result of manipulation of the gland. So as the surgeon's in there trying to get that out, a lot of thyroid hormone can be spilled into the bloodstream. And so they can have, again, that rapid pickup of those thyroid hormones that causes that increased demand in metabolism. Okay, so when you look at this, the clinical manifestations or signs and symptoms make sense if you think about what is going on in the body. We know that there's been a rapid release or a rush of thyroid hormones that have been released into the bloodstream that's caused everything to kind of ramp up and get excited. So all these signs and symptoms start to make sense. The patient's going to be hyperthermic. They're going to be hypertensive. They're going to be tachycardic. All those things can lead the patient to feeling dyspneic or having heart palpitations. They may even have chest pain, especially if you have a patient who has an underlying coronary artery disease problem. You turn everything and crank them up, and you're going to increase the oxygen demands and stuff like that. And so they can start having some chest pain, nausea, vomiting, diarrhea, abdominal discomfort. Think about people who are really stressed out. It gets everything flowing in your belly as well. Of course, they're going to feel anxious. They're going to be restless. In severe cases, yes, they can actually have some confusion, become psychotic, have delirium. Remember, there's a difference between delirium and dementia. Delirium comes on rather quickly. And because again, you have to think about everything's being ramped up. You're also going to have changes in electrolytes with this process. They can also experience seizures. Eventually, all these things can lead the patient to go into a coma, which will result ultimately, if something is not done for this patient, wind up in death. But these are all the different manifestations that you may see in a patient who is in a thyroid storm or thyroid crisis. Okay, now that we've talked about manifestations, some of this nursing care should again start falling into place with you. If you know the patient's going to be tachycardic, we know that the patient's going to be hyperthermic, they could have hypertension, they could be dyspneic, all those things, this starts to make sense. We also have established that the patient can become confused, have delirium. They may have seizure activity. They may develop and go into a coma. So all these things start to make sense. So it makes sense that number one, we're going to maintain a patent airway. That's kind of general rule with everything. These patients may require ventilatory support, especially if they become sick enough. Again, oxygen demands are going to go up because metabolic demands are going to go up, so the patient may require supplemental oxygen, and you may need to increase that to meet their demands that they're having. Because of the fact that they can become tachycardic as well as go into some dysrhythmias, this could again be related to the changes in some of the electrolytes that can be out of whack. Or again, underlying heart disease. We need to provide continuous cardiac monitoring with like a telemetry type system. You want to monitor their vital signs frequently, about every 30 minutes. And then because they can be hyperthermic, we want to try to bring that temperature down. So we'll do things like cool sponge baths. You may need to apply ice to the groin, to the underarm area, or across the abdomen. You may need to get a prescription to use a cooling blanket to help reduce that fever. I will tell you that your book on page 1270 has a really, really nice chart in it, chart 63-5, that talks about emergency care of the patient during thyroid storm, and that's where a lot of this information, as well as the information on the next slide, comes from. So I would definitely strongly suggest that you at least look at that, kind of put that one to memory. I think being able to understand what's going on, understanding your nursing interventions will be very beneficial to you when it comes to testing. Because keep in mind, you're going to have to figure out what you're going to do with these patients to help maintain them, because once again, this can be fatal. Okay, we're going to continue on with our nursing care for the patient who has thyroid storm. So we're going to administer IV fluids to provide hydration as well as to prevent vascular collapse, because keep in mind, they're just like literally cranking along like they're on, crack at this point, for lack of better terms. And after a while, the body's just going to give out. So that helps to prevent that vascular collapse. You may give acetaminophen to help decrease the temperature. It does state here that salicylates for antipyretics are contraindicated because they actually release thyroxine from protein binding sites and increase the free thyroxine levels, which is something we don't need or don't want. So for these patients, we do not want to give them aspirin preparations. We need to give them acetaminophen for temperature reduction. We're also going to administer some oral antithyroid medications as prescribed, and we're going to talk a little bit about that on the next slide. Also, we're going to probably be looking at giving them sodium iodide solutions, like 2 grams IV daily as prescribed. And what the sodium iodide does, it just helps to reduce the synthesis and the release of that thyroid hormone. So it just keeps the body from kicking out any extra thyroid into the system. And then as well, we're also going to give some glucocorticoids as prescribed, which we'll talk again about on the next slide. I have put on here up top and bottom, now that I see that, some page listings for some additional information for you guys. Again, Iggy does a really good job, and honestly, the section over thyroid storm is probably only like 2 pages long, if even that. It's not a very long section, so it's very concentrated, very direct, and very to the point. So it does not take a lot of time to read. any of the information that is presented, whether it be on thyroid storm, DKA, HHS, any of those kinds of things. So I really strongly encourage you guys to take a look at your books. Take a look at some of the pharmacology used in addition to kind of what we talked about, and some of these may repeat. But you may think about, or that they will probably use thionamides to prevent further synthesis and release of those thyroid hormones. Those are those anti-thyroid medications that helps to break down or prevent the synthesis and release of those hormones. We don't have any additional thyroid hormones spilling out into the system that are causing all the problem. Todd already talked a little bit about the sodium iodide on the previous page, but one thing to note that when you're giving thionamides with sodium iodide, the sodium iodide needs to be given 1 hour after administering your thionamide medications. So that is something that is important to note when you've got somebody on combination therapy there. They may also use beta blockers to prevent, or I should say, to block the sympathetic nervous system. Things like propranolol they may use. Basically, it's for effective treatment of systemic effects such as the tremor, the tachycardia, agitation, fever, diaphoresis, and psychosis. And then they may also use glucocorticoids if adrenal insufficiency is suspected to treat the shock. And this can commonly occur in patients with thyroid storm. I will tell you that the medications are covered pretty well in really short sentences in ATI on that page 528. So if you need to do some review of your medications, that would be the place that I would tell you to go, would be to the ATI book. Like I said, between IGI and ATI, there probably isn't more than about 2 to 3 pages of reading, and they're not even full pages because there's a lot of pictures and charts and stuff like that. So it does not take long at all to read this information on this particular process. Last thing that we'll cover is just a little bit of client education. So it's important to provide them with support and information, both to the client and to the family about the condition. Like I say, this can be kind of scary because everything's kind of ramped up. They're very anxious to begin with because, remember, they're tachycardic, they've got hypertension probably, they're probably feeling short of breath, so it can be a very scary time for them. So being able to provide that support and information to both the client and to the family is important during this time, especially if it looks like it's going to lead to the need for mechanical ventilation. Sometimes it's important for them to understand that we do that to protect our airway. We do that to help rest people. It doesn't mean that it's the end of their life. It's just sometimes that's something that we have to do. We also want to advise the client to notify the provider if they have a fever, if they have increased restlessness, palpitations, and chest pain. And then finally, to instruct the client and family that they may have mood swings, mood changes, but this should decrease as treatment goes on. Remember, it can cause, agitation, it can cause delirium. So this can be kind of another thing that's kind of scary for them, but as the treatment goes on and those thyroid hormones start to come down, this should start to subside. One thing I want to point out to you guys on page 1270 in your IGI book, it talks about when caring for the patient with hyperthyroidism, even after they've had a thyroidectomy or they've had that thyroid gland removed, that you need to assess your temperature often because an increase of even 1 degree Fahrenheit may indicate an impending thyroid storm. So if any increase occurs, you need to respond by reporting that immediately to the provider. And that's something that's important to know in somebody who has thyroid disease or has had a thyroidectomy, that if you see a temperature change of 1 degree, that could indicate an impending thyroid storm is coming on, and that needs to be reported to the physician so you guys can start taking, getting the labs, seeing if that's what's going on, and getting intervention started to help protect the patient. Now Now that we've looked at some of the hyperthyroidism critical problems, we're going to kind of switch gears and look at some things that can affect people with hypothyroidism. Already kind of discussed a little bit how with hypothyroidism, the metabolism of the person slows down, and as a result of that, you have cellular energy that is decreased, and this leads to metabolites that are compounds of the proteins and these sugars or these glycosaminoglycans, which if you look at that word, it makes sense. You've got glyco, which means sugar. Amino usually is looking at your proteins. These build up inside your cell. And what this causes is you get this buildup of this GAG that increases the mucus in the water and winds up forming some cellular edema, and actually changes the texture of the organ itself. The thing that's different with this is we oftentimes think about edema and we think of fluid as it being in a water form, but with mixed edema, the edema is mucinous or has mucus in it as well, and so that's why this is called mixed edema. Particular type of edema winds up changing the client's actual physical appearance. So you'll see things like non-pitting edema that forms everywhere, especially around their eyes, in their hands and in their feet. Can happen between the shoulder blades. They kind of get a buffalo hump, and the tongue thickens, and you'll also see edema in the larynx. So you'll hear the voice get kind of husky sounding on them. And this is just basically because of physiological functions of these things have, like I said, decreased. It leads to the buildup of this mucinous type edema. But you will see these characteristic changes in the patient. And as I've told you many times, I'm very visual, so pictures always, speak words to me or volumes to me. So this is a picture of somebody who actually has like a mixed edema, and you can kind of tell looking, she's got her mouth open there, the tongue is thickened. She's got some swelling around her eyes. If we could actually examine her on the backside, you would probably see that swelling in between the shoulder blades. And this picture actually comes out of your book, so I'm sure you've all seen this. Other further clinical manifestations, like I said, it does affect the general physiologic functions. They all do start to decrease. So if we think about what happened with hyperthyroidism and thyroid storm, where everything was kind of ramped up on steroids, the opposite is happening here. So we may see the patient have some respiratory failure. They can become hypotensive. They may become hypothermic. So if you took their temperature, it would be lower than normal. The heart is going to slow down, so you'll see some bradycardia with the possibility of some dysrhythmias occurring. The sodium and blood glucose can also be low, so you may see hyponatremia or hypoglycemia, and all these things can lead to the patient falling into a coma, which kind of makes sense. Again, if you look at all these things, if we're not getting perfusion because the patient's hypotensive, they're bradycardic, so they're not perfusing. We have issues with hyponatremia, which can affect brain function, as well as hypoglycemia. And then you throw in respiratory failure on top of that. It's easy to see why these patients easily could go into a coma. This is the thing we're trying to avoid in the patient who we know has mixed edema because of the way it can affect the body and slow things down. It can cause the heart to become kind of flabby, which makes it difficult for it to pump, which then decreases cardiac output, so perfusion to other parts of the body is compromised. So this is the thing that we're trying to avoid at all costs. This does have a very high mortality rate. About 60% of people who actually go into mixed edema coma do not survive, so this is considered a life-threatening emergency. It is rare, it is serious, it is a complication of somebody with hypothyroidism that is either not treating their disease or poorly treating their disease. So if you think about that from a nursing standpoint, one of the things that we have to do is make sure that we educate our patients who are hypothyroidism to let them know the significance and the importance of maintaining their medication regimens and following prescription physician or provider has ordered from them. Some other things that can happen here is just like with thyroid storm where we have stress be a trigger, that is also the case here with mixed edema coma happening. We can have triggers, things like acute illness, the patient may go into surgery, the patient may receive chemotherapy, as well as the use of sedatives and opioids, because if you think about that, everything is already slowed down. We know when we give sedatives and opioids, we've kind of slowed things down even further. So that just kind of sets this patient up for potential problems. So it's just something to kind of keep in mind when you're dealing with somebody who has hypothyroidism. If you start seeing signs and symptoms of mixed edema where they're have the swelling around their eyes, their tongue is thickened, they've got that husky voice, they may start to have the edema in between their shoulder blades, you might want to use caution in those patients when giving sedatives and opioids. We need to know what we need to do to provide adequate nursing care for the patient suffering from mixed edema, especially ones who are going into mixed edema coma. So just like before, and pretty much with every single disease process that can affect the patient's ability to protect their airway, we're going to want to maintain airway patency and also provide ventilatory support if need be. It does say here to be careful with your sedation, making sure to assess for adequate gas exchange, something we would do regardless, but they do want you to note that. The most common cause of death for client with mixed edema is respiratory failure. We're going to replace fluids with IVs, whether it be normal or hypertonic saline. If you think back to a couple slides, we did talk about the fact that the patient could become hyponatremic or have a low sodium level. Sometimes the way we correct that is we do a very slow infusion of a hypertonic solution to the patient. That's something that needs to be monitored slowly anytime you're giving replacement like that. We also are probably going to give levothyroxine IV as prescribed because that's what they're lacking. They're lacking those thyroid hormones. Rapid correction of hyperthyroidism can actually cause cardiac events or adverse effects, which is anytime it seems like you're manipulating your electrolytes, manipulating hormones, it's not something that you can just correct with one push of a drug. It's something you have to do over time because you have to allow the body time to accommodate for the changes that are occurring, or you can actually cause more harm than good by trying to fix it. We also may give corticosteroids IV. This is for adrenal insufficiency. Patients presenting with mixed edema coma may oftentimes have this adrenal insufficiency. And so giving stress doses of these IV steroids can be administered along with thyroid replacement. And they do this until the adrenal functions have been or can be determined to be normal because they kind of go hand in hand. So they need to be doing those things together. And then also, we're going to be monitoring the patient's temperature hourly until they are stable. Additional nursing care that we will provide to the patient with mixed edema or mixed edema coma would be to do a close monitor on their blood pressure. We've already discussed that they are hypotensive oftentimes. And keep in mind what happens if we do not have an adequate blood pressure. We've talked before about MAP, that mean arterial pressure, and we know that if the MAP drops too low, that we are not perfusing the vital organs. Things like kidneys in particular always come to mind because that's going to be one of the first things that the body tries to do without. It's going to try to perfuse the heart, it's going to try to perfuse the lungs, it will even try to perfuse the brain, but the kidneys sometimes will get left out of the picture. And so if we're not careful by monitoring blood pressure carefully, we can get them through this, but we may then have to deal with an acute kidney injury that leads to a whole nother avenue of problems that we just don't want to have to be dealing with. So close monitoring of blood pressure is something that we have to do. Maybe that we have to do something pharmacologically to raise those blood pressures. We are going to cover the patient with some warm blankets. We've already talked about that they are hypothermic. Everything starts to slow down. We're going to assess them for mental status changes. Again, this can go back to perfusion. If the blood pressure is not high enough or that MAP is not high enough and the brain is not getting perfused, you may start to see mental status changes. And we've also determined that the patient can also have hypoglycemia or hyponatremia, both of which can cause some changes in their LOC. So close assessment of their mental status is important because the situation they are in, they are probably not going to be able to mindfully turn themselves. We're going to have to do that to protect their skin. And again, we're going to have changes in LOC or their mentation, and so we have to protect their airway, and so we're going to institute aspiration precautions. I'm going to maintain continuous ECG monitoring. Again, because we can have some bradycardia and bradydysrhythmias, as well as issues with blood pressure, we want to maintain monitoring and watching their EKG or their ECG, monitoring their ABGs to detect hypoxia, hypercapnia, or an increased buildup of CO2, and or for respiratory acidosis. Again, because everything starts to slow down, you think if somebody's bradyapneic or they're not breathing fast enough, they're going to retain CO2, so that's going to become a problem as well. And then they also say to assess every 8 hours for changes due to potential for shock. This is actually an action alert in IGGI on page 1273. That just states here that mixed edema coma can lead to shock, organ damage, and death. You want to assess the patient with hypothyroidism at least every 8 hours for changes that indicate increasing severity, especially changes in mental status, and report these promptly to the primary health care provider. So you need to be doing those checks more frequently than just once a shift. Additional nursing care for the client with mixed edema is we're going to monitor their INO and also do daily weights on them. Keep in mind they are retaining. So with treatment, urine should start to increase and the body weight should start to decrease. So we should see a shift. Failure to achieve that needs to be reported to the provider because we may need to doing some adjustments to medications. We're going to treat the hypoglycemia with glucose. Whether that's something, we may have to do for the patient, whether it be IV, IM, depending on what our readings are. We may need to treat a possible infection. Remember, sometimes it's something like that triggers the mixed edema coma to occur. So it may be that we need to treat the underlying infection. Otherwise, we're just kind of spinning our wheels trying to fix the patient if we don't actually address the problem that started it. And then again, kind of talked about this on a couple slides previous about educating the client about the need that medication is for life and the importance to be compliant. I think it's really easy for patients when they're on medications, they start to feel better, to kind of forget that maybe you need to take your medications, and so they may not be as diligent. So it's part of our job to make sure they understand the seriousness of the complications that can occur if they do not adhere to the regimen that the physician or provider has placed them upon. We're going to move on from thyroid, and we're going to move on now to something that affects your adrenal, typically your adrenal gland, particularly the adrenal medulla. And this is something called a pheochromocytoma. I actually love to say this word. It's become my new favorite since I started teaching about it. But what it does, it's a catecholamine-producing tumor that arises in the adrenal medulla. It does usually occur as a single lesion. However, it can be in both or bilateral. If you think about your adrenals, where do they sit? Give you a second. Your kidneys, so they are a pair. So you could see bilateral tumors, but that's not very common. Usually it's just a single lesion that occurs. They are also usually a benign tumor. However, about 10% of them can be malignant. These tumors do produce, store, and release epinephrine and norepinephrine, which is going to start making sense when we start talking about some of the clinical manifestations, why we see what we see because of the release of that epinephrine and norepinephrine. Like I said, it releases an excessive amount of epinephrine and norepinephrine, which stimulates the adrenergic receptors and can have a wide ranging adverse effects on the body, which we will talk about here when we talk about manifestations. The cause is unknown, but they do think there is a genetic predisposition for some people that this is just an inherited disorder. Manifestations of this pheochromocytoma. Remember that this happens because of release of epinephrine and norepinephrine. And so it makes sense that we're going to see things like intermittent episodes of hypertension that can range from a few minutes up to several hours, just depending on that release. This can trigger severe headache in the client. They can have palpitations, which makes sense because everything kind of starts taking off and racing. They may have profuse diaphoresis or profuse sweating, flushing and or heat intolerance. They may feel apprehensive or have apprehension and develop tremors. They may get a sense of impending doom because of that release. May develop some pain in their chest or in their abdomen, and they may also start having nausea and vomiting, which can lead to weight loss. So the hypertensive crisis is the thing that we're trying to avoid, because that's what these patients develop, is a risk for going into hypertensive crisis, which again makes sense because what is being released, the way it triggers the body, the way it stimulates the blood pressure to rise and stuff like that, these patients can go into hypertensive crisis. So things also that can cause this are things like increased abdominal pressure from like defecation. If you think about people bearing down and doing like Valsalva, that causes a lot of increased pressure in the abdominal cavity. So this can actually trigger a crisis in a patient who has a pheochromocytoma. So think about that down the road in patient teaching. If you have a patient that has this, what might you want to teach them about defecation and stuff like that? The other thing is we don't ever want to vigorously palpate the abdomen of somebody who has a pheochromocytoma, because this could also trigger a hypertensive crisis. If you think back to peds, we talk about Wilms tumors and the fact that you never, ever, ever palpate the abdomen of a child who has a Wilms tumor. It's a little bit different because it's cancer. But just kind of put that into your memory, just like with the Wilms, you don't ever want to palpate the abdomen of a patient who you know has a pheochromocytoma, because you could actually trigger a hypertensive crisis in that patient. Some medications can also trigger this. So some of your tricyclic antidepressants, this droperidol, which is an antiemetic, an antipsychotic, and it's also used as a sedative. Things like phenothiazines, which are used for like emotional disorders, schizophrenia, some of the psychotic disorders. Glucagon can also trigger this. Metoclopramide can trigger this, as well as naloxone, which we give to counteract the effects of opioids. And then foods high in tyramines can also trigger a hypertensive crisis. So you should learn, if you haven't already, in mental health, you talk about MAOI inhibitors, that you have to caution the patient about eating foods that are high in tyramines. Same thing with pheochromocytoma. So things that are high in tyramines would be things like your red wines, your aged cheeses, your pickled or smoked meats, anything like that. You want to caution the patient that they should not be consuming, because it could actually trigger that hypertensive crisis. So what kind of diagnostic studies do they do when they suspect that somebody has a pheochromocytoma? So they do something with blood in a 24-hour urine where they look at fractionated metanephrine and catecholamine levels. These will be elevated in the presence of a pheochromocytoma. And for those patients where maybe they're not seeing, the elevation that they thought they would see, they may go ahead and do this clonidine suppression test to look at it even further. And this is used if the fractionated metanephrine and catecholamine test results are not consistent. This will actually measure the plasma catecholamine levels prior to and 3 hours after administration of clonidine. So they draw the levels, they administer the clonidine, and then they redraw the levels again to look at those. And so I've written on here that your ATI book actually on page 514 does kind of a nice job explaining the tests and stuff like that that they would use to evaluate the adrenal gland. So if you want to look at that further, you can see it there. And then something else that you might see them do is like a CT or an MRI scan. Keep in mind that these are caused from a tumor. So the best way to see that would be either with a CT scan or an MRI scan for more clarity. What kind of nursing care and interventions would you expect to see for the patient with a pheochromocytoma? Well, surgery is the main treatment option. Keep in mind, we've already discussed this is a tumor. So the post-op nursing care focuses on promoting adequate tissue perfusion, nutritional needs, and comfort measures. And the nursing care is similar to that for the client that has had an adrenalectomy or the adrenal gland removed, which you can find nursing care for that on page 1259. It is a very short little paragraph that's on the, I guess, the inside left hand side of the page towards the top. It does not take very long to read. It talks mainly about reassessing the patient very frequently, so maybe like every 15 minutes, just to assess them for the potential that they could go into shock. So I'll let you kind of look that over. You do want to monitor the blood pressure regularly. Place the cuff consistently on the same arm. Again, we talk about this a lot, trend, 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 and trend. And the best way to do that with blood pressure is to consistently use the same cuff in the same place every time. You can get different readings if you use a different cuff every time. If you've got a cuff that fits and then you turn around and use a cuff that doesn't quite fit the second time, your pressure readings could be significantly different. So you want to be consistent in how you're obtaining your readings. You want to do that in a lying and a standing position so you can see if there's any variance or changes with orthostatic position changes. You're going to assess their hydration status, and you do want to notify your provider if you start to see any kind of signs of dehydration or fluid overload. Keep in mind that the patient could be hypotensive due to fluid volume loss or because they are dehydrated. Nursing care or interventions, which we've already talked about, is we are never going to palpate the abdomen of a client who we know has a pheochromocytoma or that we suspect may have a pheochromocytoma. We're going to educate the client as to not smoke, drink caffeine-containing beverages, or change positions suddenly, because one of the main signs of this disease is complications after surgery has to do with blood pressure. So smoking, caffeine, stuff like that can actually raise the blood pressure, something that we don't need help with in the patient who has a pheochromocytoma. And then we need to provide and educate the client about the diet, which should be a high-calorie diet that's rich in vitamins and minerals. So looking at some of the pharmacology used in the patient with pheochromocytoma, usually about 7 to 10 days before the patient is scheduled to have surgery, they will start an adrenergic beta blocking agent for these patients, and this is because of that risk of severe hypertension during surgery, because they have to go in and surgically remove that. That may stimulate a release of that epinephrine, norepinephrine, which can cause the patient to have issues with an increase in their blood pressure. So they'll go ahead and start them on something prior to them having surgery. They may also have to give them some more during the surgery IV if they start seeing the blood pressure trending upwards. They may also use these short-acting alpha-adrenergic blockers after surgery for hypertensive crisis. And for inoperable tumors that are not surgical candidates, they may use both alpha and beta-adrenergic blockers to try to regulate that blood pressure. And that's something that we'd have the client monitor very, very closely at home. So the alpha blockers, they simply work to lower the blood pressure and increase the blood flow to the heart, while we know our beta blockers have a tendency to also slow the heart rate down, as well as lower that blood pressure. Um, so with your alpha adrenergic blocking agents, these are your Zosins, the ZOSIN medications. Um, so that's something that you can kind of take a look at yourself, but these are medications that may be used for these patients with pheochromocytoma. Okay, so now we're going to switch gears again. We've already talked about some of the conditions that can affect people with thyroid disorders like the thyroid storm, the myxedema coma, and then we also talked about the pheochromocytoma that looks at the adrenal medulla, or the tumor that can arise in the adrenal medulla. So now we're going to take a look at some processes that affect people with diabetes. Both of these are emergency situations, and they would be diabetic ketoacidosis, or DKA, as well as HHS, which we'll talk about here on some of the upcoming slides. So both your book and ATI do a good job kind of talking about these disease processes. It's very shortened, it's very condensed. You can see ATI, it's only like 2 pages long, and it's about 3 pages long in your e-book. So the reading for this particular lecture and unit is actually pretty short, lots of little pages that you kind of pull out of each chapter. So what is DKA? It's characterized by an uncontrolled hyperglycemia that's resulting in the breakdown of fatty or body fat for energy, dehydration, metabolic acidosis, and an accumulation of ketones in the blood and in the urine. Hence is the name diabetic. That's the root cause. Keto, because ketones are being released and the body goes into a metabolic acidotic state. So that's why we call it DKA. The onset for this is rapid, and the mortality rate is as high as 10%, even with appropriate treatment. So this is something, again, that can be a life-threatening event for the patient who has diabetes. The most common precipitating factor is infection. So if you know that somebody is a type 1 diabetic, and that's who it typically occurs in, is your type 1s. And they should become sick with an infection. This is something that we have to be careful of, because we know that with infection we have an increased metabolic demand, and so blood sugars tend to go up in patients who are diabetic that have infection. What are our risk factors for development of DKA, or diabetic ketoacidosis? Number one is lack of sufficient insulin related to undiagnosed or untreated type 1 diabetes, or not adherence to a diabetic regimen. So the patient knows that they have diabetes, they just don't choose to follow a very close diet regimen with their medications. And I'm sure we all know people who have diabetes that do this. Reduced or missed doses of insulin, so insufficient dosing of the insulin or an error in the dosage, leading to not enough insulin being given to the patient, can lead to spikes in their blood sugars. Any condition that increases carbohydrate metabolism, such as physical or emotional stressors, illnesses, infection. Already said that infection is probably the number one reason people develop DKA that are diabetic. Surgery or trauma that requires an increased need for insulin. All of these things that I've mentioned, whether it's emotional stress, illness, infection, surgery, trauma, all these different processes will increase demand from the body. And so with that increased demand comes an increase in the need for insulin and the increase in the blood sugar. So that's what puts these people at risk. Increased hormone production like cortisol, glucagon, and epinephrine. If you think back to the bullet point right above that, all those things that happen, those stress responses, doesn't matter what the trigger is for the stress response, all these particular hormones are released that increase metabolic demand and kick out glucose from the liver, because the body kind of goes into a state that, hey, I need this extra energy. So it kicks out that extra glucose from the liver, and then you don't have enough insulin to support that increased glucose that's getting dumped into the system because of that stressor that's causing it. And so hence these people wind up with uncontrolled blood sugars. And HHS, this is hyperglycemic hyperosmolar state. This is another complication of diabetes, although this one is more common in your type 2 diabetics who have a little bit of insulin reserve, but this is where you typically would see HHS is in the type 2 diabetic, particularly your elderly population with type 2 diabetes. I think I've mentioned this on a previous slide, but this used to be known as HHNS, which was a hyperglycemic, hyperosmolar, non-ketotic state. And when we look at a slide up here in a little bit that kind of talks about the differences, and you actually saw this in your homework, one of the big things that you should have noticed that differentiates these HHS from DKA is blood sugar usually is much higher with HHS than it is with DKA, but the one thing that DKA has is that spillage of the ketones, and you don't see that present with HHS, so we don't go into that ketoacidosis part of it. So that's one difference in these two processes, even though treatment is going to be relatively similar in how we address them. Another thing with this one, this is usually has an onset that's gradual. Happens over several days as opposed to DKA, which can happen much more rapidly. If left untreated, however, this can lead to coma and can lead to death. And like I said, this is most common in our older or elderly populations with type 2 diabetes. Often they don't even know that they have type 2 diabetes. And then a lot of times it's dehydration is a big factor also that can trigger this. And we all know that as people get older, they have a decreased thirst mechanism, and so they may not hydrate real well. So some people may actually develop HHS and don't even know that they are a type 2 diabetic until they get into this complication that can be life-threatening that lands them in the hospital. So some of the risk factors for HHS, lack of sufficient insulin related to an undiagnosed diabetes. There is sufficient insulin present to prevent the ketosis, because if you think back to diabetes type 1 versus diabetes type 2, people with diabetes mellitus type 2 generally have a little bit of circulating insulin, so that is enough to keep them from going into ketosis, but it's not enough to prevent them from developing the hyperglycemia that goes with this particular process. As I mentioned before, this usually one of the big risk factors is inadequate fluid intake or poor kidney function. This is most commonly seen, this particular process, in our older or elderly population. I say that, I'm in my 50s, so I just aged myself, that are between 50 and 70. Mortality rates in our older clients are actually between 40 to 70% due to the fact that they have a lot of other issues that come along with age, and also they tend not to seek attention quickly. Keep in mind, again, HHS is something that's gradual, so it comes on gradually, so they don't even realize that they're as sick as they are until they are, really feeling bad and then wind up at the hospital. And we all know, some of the older population, they're the tough generation. They tough things out. They don't need help. They think they're going to be okay, and so they wait too long before seeking medical attention. Some medical conditions such as an MI, having a CVA, or sepsis, which again, if you think of those things, those are all processes that increase metabolic demand, just kind of like with DKA. Some medications that put the patient at risk, of course, are glucocorticoids, and that makes sense because we know giving steroids to patients, regardless of whether you have diabetes or not, increased blood sugar is a potential issue. Thiazide diuretics can also give problems. Phenytoin, used oftentimes for seizure disorders. This one can actually inhibit the release of insulin, so what little bit of circulating insulin they have left, we may knock that out, which puts them at risk for developing this. Beta blockers as well, because beta cells actually produce insulin, so if you block those cells, you block the production of insulin, so again, you can have an increase in not having, having the sugar, the glucose circulating, and then also calcium channel blockers. And again, infection and stress, because like I've mentioned over and over again, this has to do more with the increased need for metabolic demand. And so the body gets into that fight or flight. One of the things it does is it tries to kick out more glucose because it needs to get you amped up in preparation to fight. All right, this slide here is looking at your complications and kind of putting them side by side so you can have kind of a nice comparison. There is a table in your EU book, I believe it is page 555, it's table 64-3. I wish I had my book open right now. Oh, that's the ATI, I'm sorry. IGGI, I think it's page 1313. Let me look that up real quick to make sure I'm giving you the correct page number, although I have confidence you guys are all smart enough to figure out how to do that yourself. It is on page 1313. So some of the differences, big one is the onset. DKA, it is typically a sudden onset. HHS, it's usually an onset that's much more gradual, so it may take, you know, a couple days for the patient to actually get really sick with HHS. Precipitating factors, you'll see some very similar things. Infections and other stressors are common for both of them. DKA, however, though, there's inadequate insulin. You could have, inadequate insulin dosing going on, so the patient is not getting as much insulin as they're needing to control their diabetes. And then again, one of the big things with HHS is poor fluid intake. And I'm going to be a broken record here, but think about our older population. They don't drink that much fluid. So it's really important when we're doing education with our type 2 diabetics, especially in some of the newly diagnosed ones who are getting their education, the importance of proper hydration so they don't get into trouble with this. I know with my mom, who's not diabetic, but trying to get her to drink fluid, she would think she was drinking all kinds of water all day long, but when it came down to it, she was probably consuming less than, you know, an 8-ounce glass, but she thought she was really packing it away because she took a couple sips when she took her pills, not even realizing that she really wasn't drinking that much fluid, but it's because she just did not have much of a thirst. So she drank coffee and things like that, but not actually push fluid. So that's something education-wise we as nurses need to make sure that we teach our patients. And then some of the manifestations that we may see, Kussmaul respirations, that's something that you will see with a diabetic. If you've ever seen it, you don't forget it. They do kind of breathe very heavily. Another thing that you will notice with somebody who is in DKA is they have a very fruity or acetone kind of smell to their breath as they're doing this rapid kind of respiration thing that they do. They will have nausea. They may have some abdominal pain. In your HHS, you'll see things like altered central nervous system functions with neurologic symptoms. They may actually go into seizure or have myoclonic or that jerking that is associated with seizure. Dehydration or electrolyte loss with DKA, you can have polyuria, polydipsia, so a lot of urinary output going on. They can have weight loss, they have dry skin, sunken eyes, soft eyeballs, they become very lethargic, and then eventually will go into a coma. And with HHS, you'll also see dehydration or loss of electrolytes, same as you will with the DKA. One thing when you're looking at your HHS, there's a reason it's called hyperosmolar state, is because of the fact that if you were to look at the osmolarity, it is greater than 350 milliosmoles per liter. So that's another distinguishing factor when you're looking at the lab work of somebody who has HHS. You will not only see an elevation in that blood sugar, and usually they're like over 600 with that, but you will also see that they are in a hyperosmolar state. So those are two kind of characteristics you want to look for with that particular disease process. Here are your laboratory findings. I guess I didn't realize that this was the very next slide. So these are, again, looking at them side by side, and this oftentimes will help when you're trying to determine what is going on with your patient, or if you're seeing a test question and you're getting labs to help you differentiate whether you think your patient is in DKA or HHS. So we look at the serum glucose levels. Usually with diabetic ketoacidosis, you're going to see a blood serum level above 300, and with HHS, it's going to be over 600. That osmolarity can be variable with your DKA patients, but it's going to be over like 320. I think I said 350 on the other side. It should be 320 is what they will be over with HHS. The ketones, you will be negative with your serum ketones, with your HHS, and you will be positive with your DKA, which again makes sense. It's called ketoacidosis for a reason. Again, looking at your pH, your blood gases are going to be out of whack because your patient is in a metabolic acidotic state. So when you think about that, we know normal pH is 7.35 to 7.45. So you're going to see somebody whose pH is below 7.35 because that is the lower end of normal. We also know that the serum bicarb, or that HCO3, will also drop in somebody who is in metabolic acidosis. So that's why you see it. It can be down as low as below 15. When you look at your blood gases on the other side of the spectrum, you'll see that your pH and your serum bicarb are okay. Serum sodium levels with DKA, they can be any of the above, low, normal, or high. And with HHS, they tend to be normal or low with that one. Your BUN will be elevated in both cases, and again, this goes back to dehydration. Creatinine, the same thing. You're going to see elevations in your creatinine levels. And then if you also look at your urine for ketones, you're going to see that they are positive in your patient that has DKA and negative in the one who has HHS. So when you're looking at all that lab, you need to ask yourself, so what things are the same and what things are going to be different? So you're going to see increases in serum glucose, but you're going to see a much higher serum glucose with the patient who has HHS. Now, I'm not saying somebody who comes in with DKA can't have a blood sugar of 900, because that does happen. It's just that parameters for diagnosis is anything over 300, but you have to have also the positive ketones and that pH that's out of whack to get you to a DKA. So just kind of look these over and just kind of be aware that what stands out, what doesn't stand out. Again, HHS, hyperglycemic, so elevated sugar, hyperosmolar. The osmolarity is going to be above that 320. So another thing we will look at when we're dealing with somebody in DKA, and your book really doesn't talk about this a lot. There's not a ton of information on it, but I know they use this in the hospital, and that is called your anion gap. And this happens because of accumulation of keto acids results in this increased anion gap. So this goes back to like your chemistry kind of days and stuff like that with pH and anions. So normal anion gap is between 7 and 9 milliequivalents per liter, and an anion gap greater than 10 to 12 indicates metabolic acidosis. So this is one of the tests that they will also look at when they suspect DKA. They will also look at it again to see how well that is correcting itself. So this does become important, especially in the clinical field and in the hospital. So I just wanted you to be aware of it, even though, like I said, your book briefly mentions it, but doesn't do a lot of discussion on it. Okay, so now we've got our patient diagnosed. What are we going to do? And the way we treat this, first of all, is to treat the underlying cause. So if we have an infectious process, we need to address the infection. Another thing is you're going to provide a rapid isotonic fluid replacement to maintain perfusion to your organs. And this is kind of like a fluid resuscitation is what they do. Typically, standard would be about 15 to 20 milliliters per kilogram per hour that is given over that first hour. And when we say isotonic fluids, think about what does that mean. It's usually going to be something like a normal saline is what they're going to start this particular patient on. They may do LR, but usually it's normal saline that you'll see, because you have to keep in mind also these patients will be receiving insulin IV, so that's what it's going to be most compatible with. Eventually what they will do is they will change that out to a hypotonic fluid, so then they will switch to something like half normal saline. So instead of being that 0.9% normal saline, it will be 0.545% saline. Eventually what happens as blood sugars start to come back down and they're giving insulin, they will probably even start giving them some D5 half normal saline, which seems kind of weird that we're going to actually be giving dextrose, but we have to find that happy balance and that happy medium. So it's not uncommon that they do that. As I didn't even notice, I'm sitting here talking and now I'm seeing it. It says when serum glucose levels approach the 250 milligrams per deciliter, they usually add in the glucose. So that's at the point where they would go ahead and add like the D5 half normal saline or the D5 to that half normal saline. And this is to help minimize that risk of cerebral edema associated with the drastic changes in that serum osmolarity and prevent hypoglycemia. So like I said, rapid isotonic fluid replacement, usually of normal saline, is what is given, 15 to 20 milliliters per kilogram per hour over that first hour. Once they get that started, then they'll eventually go to like a hypertonic solution, and then eventually they'll add in some of the D5. It does note on here to keep in mind, especially when you're dealing with these patients, a lot of these may be older populations, so you always have to think about comorbidities and what other problems might the patient have. And so if you have a cardiac patient or a patient who has a poor pulmonary function, you need to also be mindful when you're doing that fluid replacement that you're also monitoring very closely because you don't want to overload them as well. So that's just something you always have to keep in mind taking care of these patients. So continue on with our patient-centered care. We've already started the fluid bolus, that fluid hydration going on. And then the other thing they're going to do is they're going to administer regular insulin, first as an IV bolus, and then they're going to follow that with a continuous infusion. And if you ever have the opportunity in clinical to see this, you will see that they will be on an insulin protocol. It's very laid out. You'll be checking blood sugars very frequently. Usually it's every hour. And then you will be adjusting that insulin drip based upon what your numbers are saying. Blood glucose of less than 200 is your goal for resolution. But keep in mind, again, when you have these protocols, and you're doing these hourly checks on the blood glucose, if you have too big of a drop, you will actually cut back on the amount of insulin that you're giving to the patient because, again, you want to do that slowly because of the risk for cerebral edema. So it's something that you have to do, but you have to do it in a gradual and slow manner. It's kind of like that with a lot of things when you're thinking of electrolytes. You can't just try to fix somebody in 10 minutes with electrolytes. So it's something that's done over a period of time. You do need to monitor your serum potassium levels because of the way insulin, the way it will bind up the potassium and shift it into your cells. The patient can become hyperkalemic or hypokalemic. Let me get their words out correctly. So that's something that you'll also be monitoring quite frequently is your serum potassium levels. I know that there are some facilities they want you to have a serum potassium level of 3.3 before you start your insulin infusion. So that's not in the book, but I just know that can happen. So you do want to monitor that very, very closely. So you will be doing potassium replacement protocols should you need to if your potassium drops too low. You also want to make sure that your patient is being monitored carefully for cardiac dysrhythmia, so they'll be on telemetry and on a monitor so you can watch that. And one thing, and this is actually in your book as a nursing alert, is make sure that you have urine output that is adequate before administering any potassium replacement. So your urine output needs to be at least 30 milliliters per hour before you can initiate replacement of potassium or giving those IV potassium to these patients. So I would tell you to know that because I have seen that on a lot of test questions dealing with hyperkalemia as well as with DKA and HHS and the need for potassium replacement. Sodium bicarb can be given as a slow IV infusion. We've kind of talked about that when we did our blood gas lecture. But this is only used in severe acidosis cases. So if the pH is below 7.0, they may consider initiating sodium bicarb. And then you want to monitor and report any changes in neurological status in your client, especially the ones with HHS, because those are the ones who are at the highest risk for also developing cerebral edema. So you want to make sure that you're doing that hourly and checking that frequently. So finally, client education. What do we need to teach our patients? You want to teach them about ways to prevent reoccurrence. So if we're dealing with an old person, or I shouldn't say old person, a geriatric population who has type 2 diabetes, one of the first things we can teach them is to make sure they're drinking plenty of fluids. If they were to get sick, have surgery, things like that, we need to teach them ways to try to prevent or to recognize the potential that they could be developing HHS. For our diabetic patient, again, teaching them the signs and symptoms or those clinical manifestations of DKA, being mindful to, check their blood sugars more frequently, stuff like that. Encourage the client to wear a medical alert bracelet that identifies them as being diabetic. And this is actually really important. I actually know two different people that had similar instances. Both of them went into DKA. They were diabetic, of course, type 1 diabetics. And both of them wound up getting pulled over because they were driving erratic because of the fact the blood sugars were so high, and they appear to be impaired. One of my friends actually wound up getting taken to jail and put in jail by the officer. It wasn't until he finally went unresponsive that they found his medical alert necklace on him that led them to get him to help. The other one had a bracelet on, and they were able to determine pretty quickly that what was wrong with him was not that he was driving impaired or under the influence of anything, that he was actually having a medical emergency that led to his erratic driving. So this is something that's also very important. It helps also first responders. It helps when people arrive or present in the emergency room if they're in a state where they can't really tell us what's going on. It's a good way for us to make a quick identification as well that might be something that's going on. So you want to teach them about how to decrease their risk of dehydration. Consume at least 2 to 3 liters of fluid daily unless contraindicated. Again, remember, we're dealing with what might be some geriatric population. So if I have a patient who has poor heart function, cardiac function, I'm probably not going to encourage them to do that, but I am going to encourage them to stay well hydrated. If blood glucose levels are low, they need to consume liquids that have sugar. Monitor their blood glucose every 4 hours when ill and continue to take their insulin. Sometimes people, when they get sick and they're not able to eat, they think they don't need to take their insulin, but they very well may, because, like I said, being sick can oftentimes increase your metabolic demand. And so they still need to be monitoring that blood glucose level and continue taking their insulin. Additional client education is to teach the client to check their urine for ketones if their blood sugar is greater than 240 milligrams per deciliter, which is something they can do very easily at home. Teach them to consume liquids that have carbohydrates and electrolytes if they're unable to eat solid foods. They do need to be instructed to notify their provider if they have an illness that lasts longer than 24 hours, they have blood sugars greater than 250, if they have the inability to tolerate food or fluids, they see ketones in their urine for more than 24 hours, or they start running a temperature greater than 101.5 for 24 hours. Again, because these are all things that can put them at risk or indications that they may be trying to develop DKA or HHS, and so they need to be letting their provider know that they're having problems. And this is just kind of a friendly reminder slide about diabetic diets. In DUDEC, chapter 19, it talks about this. I'm pretty sure your ATI nutrition book also will talk about this, and I didn't put those page numbers down. But some of the things you want to teach them is to make sure they eat 3 meals a day with small evening snacks. They want to spread their carbohydrates throughout the day, not just like chow down on carbs in the morning and then don't eat them, because the whole point of that is to maintain a consistent level of carbs to keep blood sugar regulated well throughout the day. Choose unprocessed foods, eat foods that are high in fiber. Sugars and sweeteners can be consumed as part of their carbohydrate allowance, but it has to be limited. So if they really, 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 really want that piece of birthday cake for their birthday, they can have it, small piece, but it needs to be limited. Limit their fats, their fried foods, and also their sodium level needs to be kept below 2,300 milligrams per day. They need to choose healthy sources of fats, and alcohol should be in moderation, but not on an empty stomach. So some considerations for our geriatric population. Teach them to monitor their blood glucose every 1 to 4 hours when they are ill. They need to emphasize, again, the importance of not skipping insulin when they're ill. Kind of talked about that on one of the previous slides. I feel like I've kind of harped this one quite a bit about maintaining the hydration because, again, older populations tend to lose their thirst sensation. And so they may, again, not be thinking that they're not drinking water and they're really not consuming enough. And this is one of the leading causes for people to develop HHS. So that's something that's really big in teaching that particular population about the importance of maintaining hydration status. And then also changes in mental status can prevent older clients from seeking treatment. So again, if they live with somebody providing education to the family member as well, to kind of be aware of what to kind of look for in those mental status changes in this particular patient population. All right, so this was not on your original PowerPoint that was posted for you guys and to have during class because we were only going to do it in class. But there's 5 slides on here that is a little case study that I'd like you guys to read over. The answers to the questions are at the bottom in the notes section. But I would really encourage you to try to answer the questions before you look at the answers. And so this case study involves a 23-year-old patient with a history of type 1 diabetes who is admitted to the emergency department with nausea and abdominal pain, which ding ding should clue you in. We've talked about some of the potential side effect or clinical manifestations, and we're looking at somebody who is type 1 diabetic and now nausea and abdominal pain. They have history, right? They have a respiratory rate, of 34 a minute with deep breaths and a fruity smell to their breath. They are responsive but difficult to arouse. And so what does the nurse suspect is happening with this patient? So if you look back on some of those clinical manifestations, you should start to see this picture kind of come into place of what you suspect is going on. And from here on, I'm just going to kind of let you guys take it and do these 5 slides that do look at the case study and how this progresses. So good luck. Okay, and we've already established that I am a big lover of Khan Academy and the videos that they share, especially with the health disorders. Now when you look this up, you can't actually go to the Khan Academy site anymore, but you can look these up under YouTube. So if you go to YouTube and then just simply type in Khan Academy diabetic ketoacidosis or Khan Academy hyperosmolar hyperglycemic non-ketotic state, these videos will populate. They both do a great job explaining the different disease processes. They also talk a bit about how it's managed and why those particular interventions are used and how they work. So I highly recommend you guys kind of checking these 2 videos out in preparation for your exam. Also, when I was on my little quest to find my Khan Academy videos, I found some other videos by, it's called Registered Nurse RN, and I believe her name is Nurse Sarah. She does a series on endocrine disorders, and she actually has videos on pheochromocytoma, myxedema coma, thyroid storm, diabetic ketoacidosis, as well as hyperglycemic hyperosmolar. She still calls it non-ketotic syndrome. But it doesn't matter what they call it. Just know that HHS is HH and HHNS are one and the same. But she actually does a really nice job. She has a nice little whiteboard behind her with lots of pretty colors on it. And she goes over all the different elements to each one of these disease processes. Each one of the videos are anywhere from like 9 to 16 minutes, if I remember correctly. They don't take very long, but they're really compacted and offer a lot of really good information in a short amount of time. I tend to be very visual, even though I'm listening. Being able to see the pictures and watch her talk um, was very helpful. So I highly again recommend these videos as well for anybody who wants further review on the content.